My name is Brad Borden. I chair our Emergency Service Institute, and I have also an Associate Chief of Staff role here at the clinic. So aortic dissection can be a very, very tough diagnosis for us to make in the emergency department. And we truly have tried to do many things to keep this front and center and on our mind for every case that comes in that fits that criteria. But it truly does become for us and can be thought of as a needle in a haystack. So in our 14 EDs spread across the greater Cleveland area, we have 650,000 annual visits. Our literature says that 3.5 cases of acute aortic syndrome, aortic dissection, per 100,000 cases are going to be present. So 3.5 out of 100,000 presentations to the ED. So to do the math for you, out of that 650,000 that we see on an annual basis in our 14 EDs, only 20 cases of aortic dissection. So obviously some of our EDs see more patients than others, but again, to do the math on those 14 EDs, that's only 1.5 cases per ED. So I think you would agree with me that that's not a very big number. So let's take that, and remember in emergency medicine, we have all these cases that come to see us. They're all undifferentiated chief complaints, and we're going to try to hone them down, and we're going to try to get a diagnosis. So now if you look at those applicable chief complaints that could easily qualify for an aortic dissection case for us, chest pain, in our literature, 8 to 10% of all ED visits are for chest pain. So 50 to 65,000 of those 650 are for chest pain. So let's throw in the abdominal pain presentations, the neurologic symptoms, the back pain, the syncopes, and now we've taken that 650,000 down to an easy number of 125,000, right? And again, we're looking to cone those down, and historically, we're going to cone those down to 20 ED patients. So now, we have great clinical decision support tools in the ED and a great biomarker when we look at pulmonary emboli, right? So we've got Wells, we've got PERC, we've got D-dimer. Nice article in Circulation in January of 18 that talked about, can we get a clinical decision support tool for aortic dissection? My colleague, Steve Melton, our senior vice chair, is going to talk more about that when we get up to the panel discussion. But it's really not ready for prime time yet, what was discussed there. They had an aortic dissection detection risk score, combining that with D-dimer. It's just really not quite ready for prime time just yet for us to make that diagnosis. So we don't have things going off in the ED. The computer never sends out smoke and bells and whistles to us and starts shaking and say, think dissection, think dissection. So we don't have that. We don't have the clinical decision support tool, and we really don't have the biomarker yet. So what do we do in Emergency Services Institute here at the Cleveland Clinic to keep this diagnosis front and center for us? It's got to be top of our mind. It's got to be something we consider on our differential diagnosis. So one of the first things we do is we turn to a nationally renowned known expert, Eric Roselli, to come in and give us a grand rounds lecture. We had an hour lecture. We tape it. We webcast it. I put out a directive that basically says you got to watch this. And we had great success. We had a number of people watch that. We don't stop there with that. So we have a great onboarding program in ESI. And part of that is that we include for our new residents that come out, our new attendings that might come from a different organization, we include a great onboarding manual. And part of that manual references the link that they can go back and watch this. And just to put it in a little bit of perspective for you, we're doing resident interviews right now for next year. I asked a resident this past week that's coming out of a 4-year program, how many non-traumatic aortic dissections have you personally had in the ED that you made the diagnosis on? And he held up his finger for 1. So that's why we got to keep this front and center. We have done a great job, I think, in ESI forming a great enterprise peer review. In fact, it's been modeled by some of the other institutes here at the clinic. And, you know, sure enough, every now and then an aortic dissection case is going to come up. But we don't just state the case and what was missed. There's a primer that goes out on aortic dissection that keeps it front and center. But even more important, I think, is we put out great saves every month. And we've had far more of those great saves for those very subtle presentations of dissection in the ED. And again, we put out the primer and the references and how this was presented, how this could have been presented, other ways, et cetera. Again, all to keep this front and center on our clinicians' minds. We've got a very robust ultrasound program. So all of our attendings have to either be basic, intermediate, or advanced certified and credentialed in ultrasound. In fact, one of our young attendings hadn't been out a year, those that have graduated post 08 and above can qualify to be credentialed just from their residency training in emergency medicine. But she was so excited because she did a transthoracic ultrasound in the ED, saw the flap, and called the dissection. And I can't tell you how excited she was to make that diagnosis. We have about 150 ED physicians in our institute, but we have even more, 160 to 180 APPs. And they're out there seeing patients with us. We have guide rails and guidelines around what they can see and what they need to present to us. But we realize that it's kind of hard to expect somebody who's been in school for 2 years to have the equal knowledge base as somebody that's had 7 to 12 years. So what we've done is put together a transition to practice program. It's actually a 6-month program for them that we recently extended to 12 months, some of which they don't see patients independently for those whole 12 months. And part of that is not just a curriculum base that has, of course, aortic dissection in there, but part of it is also sim training, moulage training. We're going to have these cases presented to them by patients and sort of keeps that diagnosis, and they can say when they go out there, yeah, I've seen an aortic dissection presentation. I've seen an atypical MI in a 55-year-old female, a PE, et cetera, so that they have actually seen a case like that. And so far, that's been extremely well received. And then lastly, we've put out, as part of our risk management program, these risk management modules. We put out 3 or 4 of these a year. We've done, of course, aortic dissection, which you can see here. We've done PE. We've done OB emergencies. We do limb ischemia and a number of others. We want every one of our physicians to see, review, and do these. They get CME for these. But we really got their attention when we told all of them, this is part of about 4 or 5 things that if they don't and aren't compliant, completing all of these risk management modules, they're 3 to 4 year, that they're not eligible for a merit increase. And we hold fast to that, and I can tell you that got their attention quite quickly. So what do we do once we make that diagnosis? We have put together an excellent program. The Venu, I believe, is going to speak a little bit more on this, but it's a great thing that we can do in the ED. So we've got 3 basic diagnoses that when we see and diagnose in the ED, aortic dissection, AAA, that's either leaking or ruptured, brain attack, either ischemic or hemorrhagic, and a STEMI, that all our physicians do at that point is pick up the phone if they don't have those resources there at that site, and for a dissection, they're obviously coming to Maine, that they pick up the phone and they call, and the bird's launched. No questions asked, no insurance, no demographics, nothing, just the bird's launched, and then we'll get the information from you after the bird's launched. This has worked remarkably well. We've had this in place for a number of years, and it's been a great savior for those regional EDs that don't have the backup that they do. So thank you for allowing me to present.